welcome to this module on identifying ovarian lesions using the International Ovarian Tumor Analysis or the IOTA system. For a change, we are not going to talk about the fetus, but we are going to talk about ovarian masses, which we can frequently encounter in gynecological as well as obstetric scans. And we are going to try to use the IOTA system to make a reasonably accurate guess whether the ovarian mass is a malignant one or is it a benign one. Now remember that histopathology provides the final diagnosis in the management of a patient with an ovarian mass. However, there are certain questions which you need to answer before surgery. The first being, should we operate this patient at all? Second is what to operate. Do we remove the ovaries? Do we remove the tubes, the uterus? When to operate? Is it urgent or can we defer the surgery? Who should operate? Should a gynecologist operate or should an oncosurgeon operate? And how do you operate a patient? Should we go for laparoscopy or should we go for the traditional laparotomy to avoid spilling contents in a malignant tumor? Now, among the common benign lesions that we may see in the ovary, you are likely to come across the serous cyst adenoma, the mucinous cyst adenoma, a dermoid cyst, a fibroma which is known for its Meigs syndrome, a thecoma. Also, we often come across functional cyst, endometrioma or the chocolate cyst, and the polycystic ovary. Now, I know that the polycystic ovary is unlikely to be mistaken for a malignancy, but it does cause ovarian enlargement and therefore it finds itself in this list. Among the common malignant tumors, you have first of all the epithelial tumors, the commonest being serous cyst adenocarcinoma, the mucinous cyst adenocarcinoma, the endometrioid tumor, clear cell carcinoma. Among sex cord tumors, you have the granulosa cell tumor. Among germ cell tumors, the malignant teratoma and the dysgerminoma. The ovary is also a common site for secondaries because it is freely suspended in the peritoneal cavity, and you will often find ovarian enlargement due to secondaries from the breast, tumors from GIT, and sometimes other organs which have access to the peritoneal cavity. The first question to answer before trying to guess whether it's a benign or a malignant mass is it really an ovarian mass? And there are many other differential diagnoses which you can mistake for an ovarian tumor, such as a paratubal cyst, a hydrosalpinx, an inclusion cyst following previous surgery, a pelvic abscess, and a pelvic kidney. And the easiest way to detect whether the mass is ovarian or not is to use the sliding sign. That is, you push the endovaginal ultrasound probe slightly deeper into the pelvis, and if it is not an ovarian mass, it will slide away from the ovary. If it moves with the ovary, it is most likely an ovarian tumor. Now, the important question to answer in ovarian tumors is whether it's a benign or a malignant one. Now, I will show you these four images and ask you to guess which of these two are benign and which of these two are malignant, and you will tell me easily that the upper two images are benign. In fact, you can reach a very reasonable diagnosis on this image itself. This is a clear cyst and this is an endometrioma. The lower two images are obviously malignant. In the first lower left image, you have a big mass with a lot of color flow and it looks quite a dangerous thing. On the right lower image, you have a mixed echogenicity mass with some cystic area, some solid area, some color flow, and some ascites. So a lot of things going on there. Now, this is obviously also a malignant mass. When things are this clear, you don't really need to use complex systems to reach your diagnosis. All the time, you may not get such a clear picture. For example, let me show you this case wherein you have a 8 centimeter ovarian mass which is primarily cystic, but there is a daughter cyst within. In the walls of the daughter cyst you see color enhancement and you also see some free fluid there. So in such cases it is very difficult to conclude with certainty whether this is a benign or a malignant mass, and there can be so many others, like you see a complex looking mass here in the upper left corner. Then you see a mass which is cystic but which has got a nodule which is definitely seen also on 3D. In the lower left corner you have a solid bilobe tumor with a moderate Doppler flow, and here you have a solid looking mass with again a moderate color Doppler enhancement and absolutely no ascites or no free fluid. So in these images, it is very difficult to conclude whether it is a benign mass or is it a malignancy that you are dealing with. So in such cases, we can use the International Ovarian Tumor Analysis or the IOTA system to get a more clear diagnosis. And the first paper which was published on the IOTA system was in the year 2000, that is the terms, definitions and measurements to describe sonographic features of adnexal cell tumors. And meta-analysis which are done much later, as recently as 2014 or 2017, have confirmed that the IOTA system is a reasonably good system for preliminary analysis in a patient. Now, before we go to the actual IOTA flow, we need to look at certain terminology which are used in the IOTA system. Also, we need to be very clear regarding this terminology. Now, it looks very complex, but it isn't really, and I'm going to run you through images for each and every one of these terms. So at the end of it, you will be pretty much confident on describing an ovarian mass. So we need to describe the cystic component, the solid component. We need to talk about what type of mass it is. We need to then go to the cyst wall, Doppler, and then other signs, that is presence of acoustic shadowing or ascites. Now, when we talk about the cystic component can be either clear or anechoic. It can be low-level echos. It can have a ground glass appearance. The contents can be hemorrhagic or it might be mixed. The first image on the top left corner shows an anechoic cyst. That is when the cyst has absolutely no echoes within it. You can also have slightly low-level echoes within the cyst where you see a little bit of echogenicity, especially at the border. A ground glass appearance is when the entire cyst has got uniform low-level echoes and it is virtually diagnostic of an endometrioma or a chocolate cyst. If you see a cobweb-like appearance, it is highly likely to be a hemorrhagic cyst. A hemorrhagic cyst can also have two different echogenicities representing the fluid blood at the bottom and the clot forming at the top. And at other times, you can have mixed content, such as in a dermoid cyst, where you see that most of the cyst is anechoic, but there is some hyper-echogenic areas which represent either bone or hair. Next, you go to the solid component. A component with echogenicity similar to solid structure like the liver is called a solid component. So this is a solid ovarian tumor. The second solid component that can be there is a papilla. Papillae are wall irregularities with largest diameter of at least 3 millimeters or more. So a papilla is the smallest possible solid component. The next part of terminology that we are going to discuss is the type of mass. And the mass or the cyst can be either unilocular, it can be unilocular solid, multilocular solid, or simply solid. A cyst is called a unilocular cyst when there is only one cystic cavity. The cystic cavity can be either perfectly circular, it can be bilobed, or it can have quite an irregular shape. But as long as there is one cavity and no solid tumor, you call it a unilocular cyst. A unilocular solid mass is any mass which has got one cystic cavity and a small bit of solid area. As you can see in these images, the shape of the cystic cavity or of the solid area is not important. A multilocular cyst can be a large cystic cavity with one daughter cyst, a large cavity with multiple daughter cysts, or a large cavity divided into multiple cavities with the help of septae. A multilocular solid cyst is whenever there is a multilocular cyst with a small solid area. There can be a daughter cyst, there can be multiple daughter cysts, or there can be septae, but there should be a solid area in the mass. Whenever the solid component of the mass is more than 80%, we simply label the mass as a solid mass. Now, is this cyst a unilocular cyst or a multilocular cyst? And the answer is, it is neither. It is a unilocular solid. The next is cyst wall, and the cyst wall can be described either as regular or as irregular. For cystic lesions, it is the inner wall that is important. Irrespective of the shape and number of cysts, any cyst wherein the inner wall is regular would be called as a regular cyst. For a solid tumor, it is the outer wall which is important. So a solid tumor or a tumor which is more than 80% solid would be called a regular tumor if its outer wall was irregular. Irregular walls are again different for cystic and solid tumors. For cystic tumors, it is said to be irregular wall when the inner wall is irregular. For solid tumor, it is the outer wall which matters. The next is the color Doppler enhancement, which is described from grade 1 to grade 4. Grade 1 is when the cyst wall itself has absolutely no flow within it. Grade 2 is subjective minimal flow, wherein you can see a few bits of color here and there. Now, grade 3 is moderate flow, and grade 4 is high flow, wherein almost entirely the tumor shows color Doppler enhancement. The last two signs are very important again. One is acoustic shadowing. Now, when you see benign tumors like the dermoid cyst, you will find that beneath the cyst, the ultrasound picture is not very clear. There is loss of ultrasound signals, and this is called as acoustic shadowing. Benign tumors cause acoustic shadowing. Ascites. Ascites is defined as presence of fluid anywhere in the peritoneal cavity except pouch of Douglas, and this is very important. So if you find an ovarian cyst with some fluid in the pelvis, do not call it ascites. It is normal. It can just be some reactive fluid which is often seen. So very important, ascites is extra pelvic peritoneal fluid. This is how the IOTA system works. In step 1, you use something called as the easy descriptors to try and quickly guess the diagnosis of the tumor. In step 2, you use the IOTA simple rules. If you still can't reach a diagnosis, you go to step 3, wherein you use Adnex online calculators. You first use step 1 to see whether the tumor is benign or it looks to be a malignant tumor. In case of benign tumors in step 1, you can quickly make specific diagnosis like a simple cyst, a dermoid, or a hemorrhagic cyst. If there is still no diagnosis, you go to step 2 using the simple rules and try to guess whether the lesion is benign or malignant. If you still can't reach a diagnosis, you will go to step 3, which is the Adnex model of calculation, and try to reach a diagnosis of benign versus malignant. Now, it is most important to remember that at any point of time, surgical exploration may be considered. So the IOTA system is not a perfect system. So if you feel there is a need for surgical exploration, it can be done at any step. Let us go to the easy descriptors which are based on pattern recognition. Look at these two images. You will never make the mistake of identifying the one from the other. And why is that? Why are we able to make this diagnosis perfectly? That is because of something that our brain has called as pattern recognition. And that is exactly what the IOTA easy descriptors use. So we use 4 benign patterns and 2 malignant patterns to quickly reach a very accurate diagnosis. And the first benign descriptor is an endometrioma, which is a unilocular cyst with a ground glass appearance seen in premenopausal women. So if you have this sort of an appearance, you would quickly jump to the diagnosis of an endometrioma and be quite sure about it. Benign descriptor 2 or BD2 is a unilocular cyst of mixed echogenicity which has very definite acoustic shadowing and is seen in premenopausal women, and this is of course the dermoid cyst. BD3 is a unilocular clear cyst with regular walls and a diameter less than 10 centimeters. And if you see this kind of lesion on ultrasound, it's very obviously a simple cyst or a functional cyst or a cyst adenoma. It's a benign condition. BD4 are all remaining unilocular tumors with regular walls, a cobweb-like appearance seen in premenopausal women. And when you see this appearance in a cyst in a premenopausal woman, you would quickly jump to the diagnosis of a hemorrhagic cyst. And these are the 4 benign descriptors which enable us to quickly reach a diagnosis. Now, when you talk about malignant descriptors, there are 2 malignant descriptors, MD1 and MD2. MD1 is when a tumor has ascites, it has got moderate color flow in a postmenopausal woman, and you would label this tumor as malignant. Of course, it's very difficult to reach a specific histopathological diagnosis for malignant tumors on ultrasound alone. MD2 is not really an ultrasound diagnosis, but what it says is that when the age of the patient is more than 50 and CA125 is more than 100, it is most likely a malignant tumor irrespective of ultrasound findings. Now, whenever you have used these easy descriptors, either benign or malignant, and you have not been able to reach a reasonably accurate diagnosis, you go to step 2, which are called as IOTA simple rules. Step 2 has benign rules and malignant rules, and based on these simple rules, you try to come to a conclusion again regarding the malignant status of an ovarian mass. So you have certain benign features. Now I know that this is a lot to remember, so I'm going to give you a list, and if you see in the description below this video, you will find a link from which you can download a list easily. So the benign features are B1, a unilocular cyst; B2, a largest solid component of cyst less than 7 millimeters; B3, or the third benign feature, is when you see an acoustic shadowing; B4 is when you see a smooth multilocular cyst less than 10 centimeters; and B5 is when you see no color flow. So all these features are suggestive of a benign tumor. Among the 5 malignant features, you have M1, which is an irregular solid tumor. M2 is when you see ascites. M3 is when you have at least 4 papillary structures. M4 is an irregular multilocular solid more than 10 centimeters. And M5 is when you have high color flow. So this is how we use the simple rules. When you have at least one benign feature and no malignant feature, you call it a benign tumor. When you have at least one malignant feature and no benign features, you call it a malignant tumor. When there are both benign as well as malignant features which are overlapping, you cannot be certain of the diagnosis. So also when there are neither specific malignant nor benign features, you cannot be certain of the diagnosis. So let us take this example of this cyst which I had shown you right in the beginning. So you have an 8 centimeter cyst with a daughter cyst which is showing Doppler enhancement of its walls and a little bit of fluid only around the cyst. So to describe, as we had learned earlier, the cystic component is clear. There is no solid component within this cyst. It is a multilocular cyst. It is a smooth-walled cyst with minimal flow and no ascites and no shadowing. Remember, this bit of pelvic fluid that you see here is not called ascites. So can we use easy descriptors? Is it an endometriotic cyst or a dermoid cyst or a simple cyst or a hemorrhagic cyst? No, we cannot use easy descriptors. So we go to the next step, that is trying to use the simple rules. So now let us see which of these benign features are present in this cyst and which of the malignant features are present in this cyst. So if you go through all these benign features and malignant features, you will see that this feature is seen, that is, it is a smooth multilocular cyst less than 10 centimeters, and there is no other feature which is positive. So therefore you have one benign feature and no malignant feature. Therefore you conclude that this is a benign cyst, and the diagnosis in this case was a serous cyst adenoma. This is the second case where you have an 8 centimeter cyst with no ascites and with a papillary structure measuring 26 millimeters. So here also the cystic component is clear. There are 3 papillae. This is a unilocular solid, as I have explained earlier. The wall is smooth. Doppler is showing minimal flow, and there is no ascites and there is no acoustic shadowing. So can we use the easy descriptors? No, we cannot. What about the simple rules? Now, if you look carefully at the benign and malignant features, you will find that there are no benign and no malignant features. So clear-cut features of benign or malignant nature of this cyst are missing, in which case you label the diagnosis to be uncertain. And whenever the diagnosis is uncertain, even after using the simple rules in step 2, you go to the third step, that is the Adnex model. Now the Adnex model is very simple. It's an online calculator which is available free for use for everybody. So I'm going to give you a demonstration of the online system. To find it online, you simply go to Google, and I have already searched for it, and you search for IOTA Adnex model, and Google search will take you to the website. The first result in the Google search is this web page, and you simply add patient details. I'll zoom it for you. So the age of that patient, which we saw earlier, was 50. My center is not an oncology referral center. The maximal diameter of the lesion was 80 millimeters. The solid part was 26 millimeters. There were no locules. There were 3 papillary projections. There were no acoustic shadows, no ascites, and CA125 in this case was 400. Now when I press calculate, it first asks me for a disclaimer, which I agree to, and then it shows us the result. And if you scroll down, you will see that with all these details, there is a 79% risk that it's a malignant tumor. There is still a small chance that it can be a benign tumor, but most likely it is malignant. And out of that, there is at least a 50% chance that it is stage 2 to stage 4 malignancy. So you would possibly call in an oncosurgeon to operate such a case. So this is the IOTA Adnex model, which is an online calculator which gives you a pretty reasonable guess in most of the cases. Now, before we conclude, it is important to remember that IOTA is not a foolproof system, and surgical exploration may be considered anytime.